Okay. Our topic is about adolescent pregnancy, and this lecture was lifted from Nelson's textbook of Pediatrics 21st edition, chapter 144. Okay, the overview of the lecture is as follows. We're going to talk about the epidemiology, the etiology of adolescent pregnancy, the clinical manifestation, how to diagnose, the counseling and the management part, how to prevent the complications, and lastly, the psychosocial outcomes for the mother and the child. So this epidemiology was lifted from the United States. So the teen birth rates in the United States are at a historic low, secondary to increased use of contraception at first intercourse and the use of dual methods of condoms and hormonal contraception among sexually active teenagers. So in the United States, they already had a decreasing trend in teenage pregnancies. Okay, this improvement in U.S. female teen birth rates is attributed to three factors. First, more teens are delaying the onset of sexual intercourse. Next, they are using some form of contraception when they begin to have sexual intercourse and are using long-lasting contraceptive agents such as injections, implants, and the IUDs or the intrauterine devices. So most pregnancies among U.S. adolescents are unintended or unwanted or mistimed. 88% of births to teenagers 15 to 17 years old were the result of unintended pregnancies. So in the Philippines, a third world country, I got these statistics from the Philippine Statistics Authority. However, this was published August 28, 2014. According to these statistics, 1 in 10 young Filipino women aged 15 to 19 is already a mother or pregnant with first child. This is the final results from the 2013 National Demographic Health Survey. So I got another article, which this was published more recently, last February 8, 2021, and it states that teenage pregnancies in PH up by 7%. So this was already in the pandemic. We're already in a pandemic when this article was published. So it states that in 2019, 2,411 girls considered as very young adolescents aged 10 to 14 gave birth, or almost 7 every day. This was a threefold increase from 2000, when only 755 from the said age group gave birth. So this was really alarming, these articles were there. So for the etiology, in industrialized countries with policies supporting access to protection against pregnancy and sexually transmitted infections, older adolescents are more likely to use hormonal contraceptives and condoms, resulting in a lowered risk of unplanned pregnancy. Better personal hopes for employment and higher educational goals are associated with lowered probability of childbearing in most groups. In non-industrialized countries like our country, laws permitting marriage of young and mid-teens, poverty, and limited female education are associated with increased adolescent pregnancy rates. So that's quite self-explanatory. The clinical manifestations. Adolescents may experience the traditional symptoms of pregnancy: morning sickness like vomiting, nausea, that may also occur any time of the day, swollen tender breast, weight gain, and amenorrhea. Often the presentation is less classic. Headache, fatigue, abdominal pain, dizziness, and scanty or irregular menses are common presenting complaints. In the pediatric office, some teens are reluctant to divulge concerns of pregnancy. Denial of sexual activity and menstrual irregularity should not preclude the diagnosis in face of other clinical or historical information. Pregnancy is still the most common diagnosis when adolescents present with secondary amenorrhea. So, according to Nelson's, this table shows the diagnosis of pregnancy dated from first day of last menstrual cycle. So, the classic symptoms, I've already mentioned these: the missed menses, the breast tenderness, and teens may present with unrelated symptoms that enable them to visit the doctor and maintain confidentiality. Laboratory diagnosis: tests for human chorionic gonadotropin in urine or blood may be positive 7 to 10 days after fertilization depending on sensitivity. Irregular menses make ovulation or fertilization difficult to predict. Home pregnancy tests have a higher error rate. And physical changes 2 to 3 weeks after implantation, cervical softening and cyanosis, 8 weeks uterus size of an orange, 12 weeks uterus size of grapefruit and palpable suprapubically, 20 weeks uterus at the umbilicus. If physical findings are not consistent with dates, ultrasound will confirm. On physical examination, the findings of an enlarged uterus, cervical cyanosis, or the Chadwick sign, a soft uterus, or you call it the Higger sign, or a soft cervix, the Goodell sign, are highly sensitive of an intrauterine pregnancy. A confirmatory pregnancy test is always recommended, either qualitative or quantitative. Modern qualitative urinary detection methods are efficient at detecting pregnancy, whether performed at home or in the office. These tests are based on detection of the beta subunit of human chorionic gonadotropin, or the HCG. Although claims for non-prescription home pregnancy test may indicate 98% detection on the day of the first missed menstrual period, sensitivity and accuracy vary considerably. Office or point-of-care tests have increased standardization and generally have increased sensitivity with the possibility of detecting a pregnancy within 3 to 4 days after implantation. However, in any menstrual cycle, ovulation may be delayed, and in any pregnancy, the day of implantation may vary considerably, as may rate of production of HCG. Consequently, each negative test should be repeated in 1 to 4 weeks if there is a heightened suspicion of pregnancy. The most sensitive pregnancy detection test is a serum quantitative beta HCG radioimmunoassay with reliable results within 7 days after fertilization. This is more expensive and is used primarily during evaluation for ectopic pregnancy to detect retained placenta after pregnancy termination or in the management of a molar pregnancy. It is used when serial measurements are necessary in clinical management. Although not used for primary diagnosis of pregnancy, pelvic or vaginal ultrasound can be helpful in detecting and dating a pregnancy. Pelvic ultrasound will detect a gestational sac at about 5 to 6 weeks dated from last menstrual period, and vaginal ultrasound at 4.5 to 5 weeks. This tool may also be used to distinguish diagnostically between intrauterine and ectopic pregnancies. Pregnancy counseling and initial management. So, once a diagnosis of pregnancy is made, it is important to begin addressing the psychosocial as well as the medical aspects of pregnancy. The patient's response to the pregnancy should be assessed and her emotional issues addressed. It should not be assumed that the pregnancy was unintended. Discussion of the patient's options should be initiated. These options include releasing the child to an adoptive family, electively terminating the pregnancy, and raising the child herself with the help of family, father or the baby, friends, and other social resources. So of course, this was adapted from the US setting. So in our setting, it's illegal to terminate the pregnancy, elective termination of the pregnancy, and also about adoption. It will undergo a process if the parents want their child to be adopted, and so we can have this option: raise the child herself with the help of the family, father of the baby, friends, and or other social resources. So options should be presented in a supportive, informative, non-judgmental fashion. For some young women, they may need to be discussed over several visits. Physicians who are uncomfortable in presenting options to their young patients should refer their patients to a provider who can provide the service expeditiously. Pregnancy terminations implemented early in the pregnancy are generally less risky and less expensive than those initiated later. Again, this is from the US setting where termination of unwanted pregnancy is legal. Other issues that may need discussions are how to inform and involve the patient's parents and the father of the infant, implementing strategies for ensuring continuation of the young mother's education, discontinuation of tobacco, alcohol, and illicit drug use if there is any, discontinuance and avoidance of any medication that may be considered teratogenic, starting folic acid, calcium, and iron supplements, proper nutrition, and testing for sexually transmitted infections. Especially in younger adolescents, the possibility of coercive sex must be considered and appropriate social work or legal referrals may be made if abuse has occurred, although most pregnancies are not a result of coercive sex. Patients who elect to continue their pregnancy should be referred as soon as possible to an adolescent-friendly obstetric provider. Risk factors for teen pregnancy include growing up in poverty, having parents with low levels of education, growing up in a single-parent family, fewer opportunities in their community for positive youth involvement, neighborhood physical disorder, foster care, and having poor performance in school. The importance of prevention, teen pregnancy and childbearing bring substantial social and economic costs through immediate and long-term impacts on teen parents and their children. In 2010, teen pregnancy and childbirth accounted for at least $9.4 billion in cost to U.S. taxpayers for increased health care and foster care, increased incarceration rates among children of teen parents, and lost tax revenue because of lower educational attainment and income among teen mothers. For the adolescent fathers, those who become fathers as adolescents also have poorer educational achievement than their age-matched peers. They are more likely than other peers to have been involved with illegal activities and with the use of illegal substances. Adult men who father the children of teen mothers are poorer and educationally less advanced than their age-matched peers and tend to be 2 to 3 years older than the mother. Any combination of age differences may exist. Younger teen mothers are more likely to have a greater age difference between themselves and the father of their child, raising the issue of coercive sex or statutory rape. Male partners have a significant influence on the young woman's decision, desire to become pregnant, and to parent her child. Sensitively and appropriately including the male partner in discussion of family planning, contraception, and pregnancy options may be a useful strategy in improving outcomes for all. This can only be successful if the young female patient is willing to have her partner involved in such discussions. Medical complications of mothers and babies. Although pregnant teens are at higher than average risk for some complications of pregnancy, most teenagers have pregnancies that are without major medical complications, delivering healthy infants. The miscarriage or stillbirth risk for adolescents is estimated at 15 to 20%. In the United States, elective pregnancy termination rates peaked from 1985 to 1988 at 41 to 46%, decreasing since then to approximately 30% in 2008. Teen mothers have low rates of age-related chronic disease like diabetes or hypertension that might affect the outcomes of pregnancy. They also have lower rates of twin pregnancies than older women. They tolerate childbirth well with few operative interventions. However, compared with 20 to 39-year-old mothers, teens have higher incidences of low birth weight infants, preterm infants, neonatal deaths, passage of moderate to heavy fetal meconium during parturition, and infant deaths within 1 year after birth. The highest rates of poor outcomes occur in the youngest and most economically disadvantaged mothers. Gastroschisis, although rare, has a much higher incidence in infants of teen mothers for reasons that are unclear. Teen mothers also have higher rates of anemia, pregnancy-associated hypertension, and eclampsia, with the youngest teens having rates of pregnancy-associated hypertension higher than the rates of women in their 20s and 30s. The youngest teens also have a higher incidence of poor weight gain during their pregnancies. This correlates with the decrease in the birth weights of their infants. Poor maternal weight gain also has correlated strongly with teens' late entrance into prenatal care and with inadequate utilization of prenatal care. Sexually active teens have higher rates of STIs than older sexually active women. Globally, many young women who become pregnant have been exposed to violence or abuse in some form during their lives. There is some evidence that teenage women have the highest rates of violence during pregnancy of any group. Violence has been associated with injuries and death as well as preterm births, low birth weight, bleeding, substance abuse, and late entrance into prenatal care. After childbirth, depressive symptoms may occur in as many as 50% of teen mothers. Support from the infant's father and the teen's mother seems to be especially important in preventing depression. Pediatricians who care for parenting teens should be sensitive to the possibility of depression as well as to inflicted injury to mother or child. Appropriate diagnosis, treatment, and referral to mental health or social agencies should be offered and facilitated. For the psychosocial outcomes, risk for mother and child, educational issues, pregnancy and birth are significant contributors to high school dropout rates among girls. Mothers have given birth as teens generally remain 2 years behind their age-matched peers in formal educational attainment, at least through their third decade. Maternal lack of education limits the income of many of these young families. Substance abuse. Teenagers who abuse drugs, alcohol, and tobacco have higher pregnancy rates than their peers. Most substance abusing mothers appear to decrease or stop their substance abuse while pregnant. Use begins to increase again about 6 months postpartum, complicating the parenting process and the mother's return to school. Repeat pregnancy. In the United States, approximately 20% of all births to adolescents' mother are second order or higher. Prenatal care is begun even later with the second pregnancy, and the second infant is at higher risk of poor outcome than the first birth. Mothers at risk of early repeat pregnancy include those who do not initiate long-acting contraceptives after the index birth, those who do not return to school within 6 months of the index birth, those with mood disorders, those receiving major child care assistance from the adolescent's mother, those who are married or living with the infant's father, those having peers who were adolescent parents, and those who are no longer involved with the baby's father and who meet a new boyfriend who wants to have a child. To reduce repeat pregnancy rates in these teens, programs must be tailored for this population, preferably offering comprehensive health care for both the young mother and her child. Healthcare providers should remember to provide positive reinforcement for teen parenting successes, such as complimenting parents when they are doing a good job. So, the 2012 American Academy of Pediatrics Clinical Guidelines, Care of Adolescent Parents and Their Children. So, guideline create a medical home for adolescent parents and their children, provide comprehensive multidisciplinary care, contraceptive counseling, encourage breastfeeding, encourage high school completion, assess risk of domestic violence, encourage adolescent parenting, adapt counseling to developmental level of adolescent, awareness and monitoring of developmental and progression of infant and adolescent parent. Children born to teen mothers. Many children born to teen mothers have behavioral problems that may be seen as early as the preschool period. Many drop out of school early, become adolescent parents, or if male, are incarcerated. Explanation for these poor outcomes include poverty, parental learning difficulties, negative parenting styles of teen parents, maternal depression, parental immaturity, poor parental modeling, social stress, exposure to surrounding violence, and conflicts with grandparents, especially grandmothers. Comprehensive programs focused on supporting adolescent mothers and infants utilizing life skills, training, medical care, and psychosocial support demonstrate higher employment rates, higher income, and less welfare dependency in participating adolescents. Prevention of teen pregnancies. Adolescent pregnancy is a multifaceted problem that requires multifactorial solutions. The provision of contraception and education about fertility risk from the primary care physician is important but insufficient to address the problem fully. Family and community involvement are essential elements for teen pregnancy prevention. Strategies for primary prevention preventing first birth are different from the strategies needed for secondary prevention, preventing second or more births. Common components of most successful evidence-based programs to prevent teen pregnancy. Information is provided about the benefits of abstinence. Information is provided about contraception for those who are already sexually active. Information is provided about the signs and symptoms of STIs and how to prevent STIs. Interactive sessions on peer pressure are presented. Teenagers are taught communication skills, and programs are tailored to meet the needs of specific groups of young people. Abstinence-only sexual education aims to teach adolescents to wait until marriage to initiate sexual activity, but unfortunately does not mention contraception. Other educational programs emphasize HIV and STI prevention and in the process prevent pregnancy, whereas others include both abstinence and contraception in their curricula. Sex education and teaching about contraception do not lead to an increase in sexual activity. Teenagers who participate in programs with comprehensive sex education components generally have lower rates of pregnancy than those exposed solely to abstinence-only programs or no sex education at all. Home visiting by nurses has been successful in some areas, and many communities have developed teen-taught clinics that provide a one-stop shopping model for healthcare for both the teen mother, the baby, in the same site at the same time. In the practice setting, the identification of the sexually active adolescent through a confidential clinical interview is a first step in pregnancy prevention. The primary care physician should provide the teenager with factual information in a non-judgmental manner and then guide the teenager in the decision-making process of choosing a contraceptive. When a teenager does become pregnant and requires prenatal care services, healthcare providers should remember that the pregnant teenager is an adolescent who become pregnant, not a pregnant woman who happens to be an adolescent.